everybody. Welcome to today's webinar. I am Pamela King, and I am looking at how you can see this presentation right now. Hold on one moment. There you go. Hello, everybody. Welcome again to today's virtual panel discussion on the Florida HIEs Encounter Notification Service, or ENS as we lovingly refer to it. On behalf of the agency, I'd like to thank everyone for joining us today for this special virtual panel discussion on the use of ENS by FQHCs here in Florida. Before I introduce today's moderator and panelists, I would like to provide a short overview of the Encounter Notification Service for those of you that may be joining us for the first time. Or even some of you that have been with us before, we do have some updated statistics for you. The Encounter Notification Service basically provides alerts or notifications in just about real time on patients that you may have that are receiving care at participating Florida hospitals. Right now we have a little over 255 data sources, and that includes 95% of the acute care bed hospitals here in the state of Florida. We've recently added rehab hospitals, and so we have 80% of the rehab hospitals in the state of Florida. So really good information data being shared. These are real-time encounters. The way you receive those depends on how you sign up for the service. So, and we provide a lot of that information in some of our regular webinars, those down and dirty details on how you can subscribe, that kind of thing. It is inpatient and emergency counter data, and basically it's those admit, discharge, and transfer feeds that are already being shared within hospitals and provider offices today through their EHR systems. Right now, for FQHCs here in Florida, we do have, in general, for subscribers to the service, we have over 100. We have about 110 subscribers. Of those, 49 are provider organizations. 19 of those 49 are community health centers. And eight of them have been receiving data for almost 1 year. So we're starting to see some interesting or get some interesting feedback or get feedback from those FQHCs that have been using the data for a year now. And we're looking forward to hearing more about the benefit of receiving that encounter data and how that is working to improve the care that is being provided to patients for the FQHCs. We have been working with Diane Gaddis and with Community Health Center Alliance and her team to reach out and get to FQHCs, and they work with them. And I'll introduce Diane a little bit later. She's our moderator, but she really is working with FQHCs here in the state of Florida to help them move through the process of onboarding and working with them on how to use that data and push it into the workflow. Question that I always get is, so what does this cost? There is a cost to subscribing to receive the ENS data. For providers, which FQHCs would be, it's 30 cents per patient per year with a minimum of $2,000. So it'd be $500 a quarter that to cover the cost of ENS. There is funding for FQHCs to try the service for a year. We've gotten some good feedback from some subscribers about how that 1 year really did help them figure out how to get it into the data into their workflow and how to demonstrate a return on investment. So we're really excited to get more information about that. from all of our subscribers. The funding is limited, and it covers the cost for 1 year only. So just throwing that out there so you guys know. I know all FQHCs are trying to treat a very distinct population, and so funding is very important to you in being able to meet the services. With that really high level overview, I'm going to introduce our panel for today. First, our moderator is Diane Gaddis. She is the CEO and president of the Center for the Advancement of Health IT, which is a nonprofit program committed to serving healthcare organizations who pride themselves in delivering quality care to the communities they serve. Diane has been working in this industry for a couple of years. She's, not too many. I don't want to say too many because then that we're about the same age. She started yesterday, right, Diane?
Yes, just a couple weeks ago.
Yeah. Many of you may know Diane. She actually has been the foundation of your organization was over 15 years ago. I know that. So does great work and 25 years experience in the healthcare sector. Although she is too young to have been doing it for 25 years. We also have Dr. Andrew Hein. Dr. Hein is a graduate of Nova Southeastern University. He completed his family medicine residency at Palmetto General Hospital in Miami and an MBA from the Florida Institute of Technology. And he currently serves as the Chief Clinical Information Officer for Central Florida Healthcare and has been with the organization for 6 years. His interests include anything involving being outdoor. So does that mean you see patients outdoors, Dr. Hein?
I wish, but not yet.
Man, if you did, I think I would move down to Central Florida. We also have Jason Burgos. I'm going to say his name totally wrong, and he can correct me. But he is the director of the Health Support Services at Brevard Health Alliance. I'm going to go with Jason, is responsible for the federally qualified health center's IT infrastructure, helping facilitate quality improvement, and most importantly, assuring patient satisfaction. Jason and his team have helped ensure Brevard Health Alliance is a HRSA Quality Leader Awardee, an Access Enhancer Awardee, and an Advancing Health IT Quality Enhancer Awardee. He's overseen numerous efficiency and quality initiatives. He holds a Master of Science degree from Community Health with a specialization in Health Policy and Administration from the University of Illinois of Urbana-Champaign. So we're really excited to have two perspectives and both the clinical and the IT perspective. With that, I'm going to turn it over to Diane, who is going to lead our conversation.
So good morning, everyone, and welcome. And thank you, Pam, for using an outdated photo of me. It helped continue the premise of I haven't been in the business very long. I appreciate that. With that, too, I wanted to go ahead and give an update, Pam, that maybe you don't even know. We are now up to 20 health centers live on ENS. I think the 20th one just went live in the last week, and we have 4 more in the queue. So the health centers are picking up on the benefits of the offering and what this can do for their patient care. So that's exciting progress. So with that, just a quick check-in. I want to make sure that I can be heard. Pam, you can hear me, right?
I can.
Awesome. So thank you again, Dr. Hein and Jason, for you joining us this morning to share some of your thoughts and experience with your colleagues across the health center arena here in Florida. Let me start with you, Dr. Hein. You've all been live on this ENS service now for almost a year. I think it's been about 11 months actually for both you and Jason's organization, Brevard. With the funding that came through the grant process in partnership with ACA and CMS, how have you found that helpful to your health center, Dr. Hein, in looking at ways to tweak workflows or how you would measure the success and determine value or return on investment with the ENS service?
Yeah, it's definitely been something very valuable in terms of, giving us that real-time information and a little bit of oversight into what's happening with our patients outside of the health center. Especially with the push towards value-based care and our accountability towards managed care and those types of things, having that degree of information has become extremely important in helping to better educate and manage our patients transitioning from the hospital, or even hopefully preventing them from having to go to the hospital in the first place.
And Dr. Hein, just a little bit of a follow-up on that. Because you were able to benefit from the grant, this first year of funding being at no cost, that's allowed you to do this with your total patient population initially, correct?
Yeah, so we decided to kind of cast a wide net initially and just open it up to our patient population as a whole, and see, what this is going to look like as we figure out, the work through the kinks of whatever issues would come up. And doing that enabled us to get a good sense of the types of notifications we'd be receiving. And then going forward, we are probably going to, we are definitely going to be narrowing our panel down to a more defined group that we really have found more of a benefit from.
That makes sense. Jason, what about you? How has the funding helped Brevard Health Alliance in kind of looking at the benefits of this service and tweaking workflows and so forth to help you determine if it's of value and how you may move forward with it?
Yes, the ENS service has allowed us to make far more efficient workflows, especially with our ED Navigator program. So we have a partnership with our local community hospitals, and we actually stationed FTE ED Navigator associates in those hospitals to decrease readmission rates. And by using the ENS platform, we've been able to identify our patients in close to real time, and then I run that report daily and disseminate it to our ED Navigators spread across the system. And in some cases, in addition to doing follow-up phone calls to establish those patients with follow-up appointments, we've actually been able to track down some of those patients while they're still in the hospital to have those real-time face-to-face interactions, providing education, just different prevention strategies. And it's made a great impact with our readmission rates. Last year, looking at our readmission rates, we're higher than the Florida as well as the national averages. We're at 17.29% for our readmission rates. And ENS was a big part of getting our readmission rate down to 8.59% for 2018, whereas the U.S. readmission rate was 14.9% and Florida was 15.5%. So it's a pretty huge accomplishment. And yeah, it's been very efficient working with the ENS report and disseminating it across the ED Navigator team.
Very good, very good. So with the kind of, stepping back a little bit, if you could kind of both of you go back 11 months to when you started this process, there's the initial subscription document, and then there's an onboarding checklist that organizations have to complete initially. And for those on the call who may not have started down this road or still contemplating, what's it take to make this happen, if you can recall, going back in time again, Jason, from the time you completed the paperwork to the time you started getting your first alerts, was that, 30 days, 6 months? What was that time frame for you guys?
If I recall, I believe it was a period of 2 months. We were we as an organization, we're still in a unique scenario where we're partnered with one of the local hospital systems. They house our databases as well as our EMR. We're currently making our transition to develop our own IT infrastructure and getting on a new EMR platform. But back then, we had to go through the channels to create a new report, an ENS patient panel report, through our community partner. And that allowed us to generate all of our patients belonging to each of the insurance groups. So I run that now that that's established, and then get that over to refresh our ENS panel. But this was just one of the channels, the steps that we had to go through in order to properly onboard. I know it's more of a unique scenario.
Right. So you had a couple other hurdles to jump through in order to submit your patient panel to ENS to get those alerts. Dr. Hein, do you recall what that time frame was for you all?
It was about a similar time frame. We have our own EHR. It's a cloud-based EHR. We use Athena Health. So we were able to get kind of our patient population very quickly loaded up into the SFTP site. And I think it was probably about a month and a half time frame. From my recollection, that's probably about the time frame it was.
All right, very good. Thank you for that. So Dr. Hein, staying with you a little bit here. So during the last 11 months you've been using the service, what other information would you share that would be beneficial to other health centers, even providers in general, lessons learned as you worked through those workflows and tweaking internal processes and getting those alerts? What lessons learned would you share with others?
Sure. So when we started out, we started with kind of a centralized approach. We were going to use kind of what our quality managed care team, who kind of was overseeing that, to take ownership and really control getting those patients in for hospital follow-ups and doing all those types of things. What we found is that the centralized process for our organization did not work the best. And so in conjunction with actually some developments that we had with Audacious Inquiry and Athena Health being able to establish an interface, we now have a process where the ownership of the ENS information is actually in each of our clinical locations. And so we have clinical nurse manager and support staff that are taking charge of getting those patients in and monitoring that information that's coming in from the ENS. All
right, very good. And that integration that you spoke about there briefly, that is definitely the direction that HRSA wants to see health centers going and integrating the data sources, and especially the external data sources, into their EHR. So kudos for getting that going. Jason, what about for Brevard? Other lessons learned that you might want to share with other health centers as you move through this process in the last 11 months?
First and foremost, the workflows. We knew that we wanted to make it as efficient as possible with disseminating it across the ED Navigator team. So we strategized and thought it'd be best to, of course, assign each ED Navigator the hospital that they're personally responsible for being on site at those hospital locations. But we wanted to also capture the patients that were being seen at non-Health First hospitals. So we strategically assigned them each of those additional hospitals as well, essentially sharing the wealth among the team then. So that way their daily responsibilities are manageable then, and all the patients receive that outreach. And then just thinking ahead, we have our on-site HRSA coming up in June. This data is going to be very valuable to show them that we've conducted this outreach on a daily basis, reaching out to our insured patient panels and then tracking the outcomes. Our ED Navigator team tracks how many patients were successfully contacted, if voicemails were left, and the number of attempts that those outreach attempts are made then. Really it's going to be beneficial to show them, and also this data is very useful to have on hand when you meet with your insurance representatives, and this correlates with those readmission rates that the ACOs present to you. This has been very valuable to present to them.
Yeah, so that's a great point, especially about the HRSA site visit and what you're able to show them. So staying with you for a moment here, Jason, what would you say to other health centers who have not yet started on this? And I'll share with you that some health centers say, well, I already get some of these alerts through my insurance partner, which, as we all know, that doesn't include the self-pay patients. So with what you're describing, you're going to be able to share some important data that with HRSA that demonstrates that you're addressing gaps in care that may exist for self-pay patients as well. What other things would you share with your colleagues about why they should take advantage of this, especially as an FQHC?
So, yeah, just by receiving this data, you have the ability to drastically close the gaps in care in a far more timely fashion. And I think the best way to answer this is comparing it to where we were prior to using ENS. There would be a period of 30 days where we'd essentially be in the dark if our patients were seen in the hospital, unless, of course, our ED navigators touched them and scheduled them follow-up appointments by seeing them face-to-face. But the ED navigators, they're not there 24/7. They only work 10-hour shifts, so some patients get missed. But with the ENS list, they can conduct those calls. So even if we do miss a patient, whether it's insured, uninsured, self-pay, we could still commit or carry out the calls to them, and then just being able to document the timeliness of those follow-up appointments compared to the date that the patient was seen, the number of outreach attempts, being able to create percentages of patients successfully contacted as a result of the ENS list. It's very good data to show that you're improving access to care, timeliness of follow-up, and yeah, just closing the loop on the follow-up process.
Very good. Dr. Hein, your thoughts on that for other health centers in considering this service?
I think that, one thing that has been really beneficial is that a lot of times patients don't necessarily disclose the frequency with which they go to hospitals. A great example discovered this week, a patient that was coming in for a hospital follow-up, said, they had just been to the hospital. We got that hospital's records fine, but what we found in his ENS feed was that he had actually been to 3 separate hospitals over, the past month, for a total of, I think it was 3 admits, and then the others were just ER visits. And so sometimes, patients say, yeah, they've been in the hospital, but they don't really necessarily say that they've been to all these other hospitals because they're having, CHF exacerbations at a more frequent rate or whatever it may be than they're willing to share, or that maybe they don't even think is relevant.
So kind of on that same point, obviously we're all concerned about the opioid crisis across the country. With that kind of scenario where you're discovering additional information that you may not know about a patient, how do you see this service potentially positively impacting our nation's efforts towards addressing that crisis?
I think that's always going to be kind of maybe a challenge, but in terms of the information that this ENS feed provides, like I said, it does provide us more oversight. Probably the most beneficial thing in tackling the opioid crisis is really the state database, the PDMP, and the efforts that are happening around that.
Thank you for that. So, Jason, with 11 months now, and I know you guys are looking at what patients you are submitting to the vendor for getting those feeds, you may look at refining and limiting that patient panel a little bit. Can you talk a little bit about where Brevard Health Alliance is and possibly tweaking what panel they monitor of patients and how you make that decision?
Yes. Well, right now we submit all of our insured patients, but looking ahead when we make the switch to eClinicalWorks, and that's currently looking like it's going to be an August timeframe, we've been having a lot of preliminary discussions on how we can create registries of patients, and that EHR has the capability to create registries based on what insurance group that patient belongs to. So we definitely want to be able to assess each insurance category, then break it down by readmission rates for each insurance company, then timeliness of care, and then how many patients we're able to successfully contact and get seen from the hospital at our clinic locations. We want to just be able to drive essentially deeper into the data at that time. Right now we still have limitations with our current EMR centricity, but that's a forecast of what's up and coming for us.
Dr. Hein, what about you all, Central Florida Healthcare? How are you considering refining the patient panel that you monitor through the ENS service?
Yeah, so like I said earlier, we really cast a wide net. We said we want to see kind of everything that's going on with the patients. If we are supported in doing that through the funding from the program initially, then we want to kind of get a good handle on what's going on and then refine it down. Definitely where the return on investment comes in is around managed care. When we are dealing with value-based contracts or we're dealing with managed care companies that continually have discussions with us on ensuring that we are preventing readmissions, that we are getting those patients in to be seen and keeping them out of the hospital, that's where the return on investment's been. So when we finally take that final step to narrow it down to the most valuable panel, that's what we're going to be looking at.
All right, that makes sense. So staying with you, Dr. Hein, here, we've talked a bit about, how this service has impacted improved patient care and care coordination. Any other thoughts you'd add related to those efforts? And if you could almost pinpoint the greatest value you've derived from the ENS, what would that be?
Sure. So I think that in terms of value, last month, for instance, we saw a double the number of hospital follow-up appointments on a year-over-year basis for that month. And we've seen that consistently, that, getting this information, reaching out to those patients and getting them in, number one, it's going to increase those visits. It's going to get those people in to be seen. And then we're also going to be hopefully keeping them healthier. So, the idea that patients often, when they are getting into the hospital or getting into the emergency room, their medications are being changed. They now have, new things that they've been started on, and those type of issues can create real concerns around the quality of care that patients are receiving.
Wow, so those numbers you shared, that's impressive, and good points about the changes that can happen when a patient's admitted and how that can impact your care as well. Jason, what would you say as far as how the ENS service, you've already shared a lot about what Brevard has done with patient care and care coordination. Again, greatest value if you could summarize it.
I think decreasing the readmission rates has been one of our greatest accomplishments through this service. Again, in 2017, we had a readmission rate of 17.29%. In 2018, we got that down to 8.59% as a result of the ENS platform. So, and that aligns with the main goal of the ED Navigator program, is to enlist timely care for our patients and to provide education to keep them out of the ED, but rather get them to utilize our primary care services instead. And by the fact that we've been able to cut down that readmission rate so drastically, we're keeping patients out of the hospital and we're keeping more patients in our primary care medical home instead.
Yeah, and so to go back to your point from earlier, your ED Navigator program is all about getting somebody into the hospital while the patient's still there to help educate them on your extended hours, services, and when and why there may be a better alternative than going to the emergency room. Is that pretty much the initial purpose of the visit?
Absolutely. That's the main goal of our encounters with our ED Navigator program.
Very good. So, Dr. Hein, any additional thoughts, benefits, recommendations you might have for your health center colleagues that we haven't covered today?
I definitely would say that, for those who haven't taken advantage of, having at least a look at the system and the process to really explore it. We are at a point right now in healthcare in our country, I think, where all organizations are going to have additional pressure to provide value and have that kind of value-based care model work. And doing things like this where we have the greatest amount of information about our patients provides for the ability to really maintain an organization that is seeing all the pressure to provide value-based care.
Yeah, thank you for that. Jason, thoughts, benefits, additional insights you'd want to share with the health center colleagues?
Yes, absolutely. The platform, it'll give you highly valuable data. It'll allow you to make an impact in close to real time on your patient population. Like I said, before we had the ENS platform, we had to wait at least 30 days to receive actionable data, and in a lot of cases, it'd be too late to do anything about it to conduct the effective outreach to the patient. So, yeah, we've been able to decrease the readmission rates drastically over the past year through ENS, and just having this data on hand, it looks really good for accreditation, for audits, but most importantly, at the end of the day, it's about the patient and improving their outcomes and timeliness to care. So I believe that's the greatest value.
Yeah, and Jason, I think in one of those points there, you highlighted another reason health centers should consider doing this, even though they may be getting some of those alerts through their insured or ACO relationships, is that sometimes that data is delayed a bit, and with your own direct feed, it's more actionable and you can make more of an impact by getting it directly. So thank you for that. So one last thought I'd like to just share with the listeners on the call today is that the grant funding is still available that was highlighted, but it is running out. It is on a first come, first served basis. So we want to make sure that health centers get opportunity to take advantage of that while it is still available. As we all know, you never know if another opportunity is going to avail itself. So we want to take advantage of what we have today. So with that, Pam, did you want to open it up for other questions from any attendees?
Absolutely. So if you have a question, this is your opportunity to ask folks that are using this service and can share with you the good, the bad, and the ugly. So it's your opportunity to ask those questions. If you would like to, you can either click on in the toolbar, click on the hand that will raise your hand for me, and I will unmute you and you can ask your question, or you can type your question in the question panel within the toolbar. So I like to give it a few seconds because sometimes it takes folks a little bit of time to start typing those questions. With that, I'm going to ask a hard question here, wait. I don't have to ask a question because I've gotten one. Hold on one second. The question is, are either of you receiving behavioral health information? They said specifically clients entering a Baker Act. So the question is about behavioral health data. Are you getting information about patients related to behavioral health. And
so
so
we have not seen anything. We have not seen anything coming from a Baker Act receiving facility. These notifications are just that they are strictly a notification. So if they, say patient presented to emergency room, it is a, emergency visit and ER visit for whatever psychiatric illness. Now, if that patient was a Baker Act or something like that, that information isn't shared out of the ENS itself. These are strictly notifications and not clinical documentation.
Right.
Yeah, it's been the same for us. We don't receive the diagnostic information based on behavioral health, for the ENS level, but our ED navigators, once they go see the patients, discharge summaries are provided to our staff, and actually our providers have access to view electronically from our hospital partners in the system to view that information at that point.
Okay. There is, this is Pam, so I'm going to add in the information that's provided. I think the only clinical information is the discharge diagnosis or discharge diagnosis code and discharge disposition if that's available. And so it could include a behavioral health diagnosis. The data going out is only coming from those facilities that are sharing data. So the information you get is going to be dependent on those facilities that are sharing the data. We do require that any patient that is on a panel, and our two panelists and Diane can add to this, but you do have to have patient consent to have them on your panel to receive information. So they have to sign a patient consent.
Yeah, and with that, Pam, this is Diane. So we recommend that all health centers adopt a universal form. ALCA has a sample out there because as we all work to expand the reach of what information we get to help our patients, that universal consent will become the norm.
Okay. There's a question about confidentiality issues. I think we may have covered this, but it says, how are confidentiality issues relating to HIPAA and high-tech as well as other Florida laws addressed? And I think Diane kind of covered that.
Yes, I mean, your universal consent, and then from a security risk analysis perspective, which we provide for many of our health centers covered under our grant, you want to make sure that you have the right person with the right permissions seeing and managing those alerts. So yeah, it's all HIPAA covered, if you will.
And then we do have a question about do any grant opportunities cover the cost of the system or the integration? I'm not sure that I understand the question, Dina. I'm going to unmute you if that's okay. And could you, I'm not sure that I understand what the question is. Can you repeat your question for us? You are unmuted. But I cannot hear you.
Pam, I'll go ahead and speak to that, and if they're able to chime in, that's great.
Okay.
Yeah, there's no system needs on the health center's end. This is all handled cloud, if you will, or via direct messaging. So there's no additional system needs to participate and take advantage of ENS. And the current grant that is available with ACA's partnership with CMS helps pay for that first year of subscription fees. Where there may be fees that would come from any integration with an EHR, and of course, as we all know, that is determined and dictated by the EHR vendor. And so that's kind of, something outside of ACA or Audacious Inquiry's hands. I hope that addressed the question.
Now I understand, I think I understood that, Dr. Hein, your organization is integrating it into your EHR system, which is separate from getting that the service separately. So maybe the two, Dr. Hein, you can talk about the integration, and maybe Jason, you can talk a little bit about how you receive the data.
Sure. So we as of about the beginning of March, completed an integration into our EHR. Previously, we were using Audacious Inquiry's prompt system to kind of monitor the feeds coming in. Now those feeds are directly tied to the patient in the EHR. So our clinical team doesn't need to go out anywhere else into other portals or anything like that to monitor or see this data. It comes into the workflow, into a central inbox that's monitored, but that is actually with information that is in the patient's record.
Okay. And then, Jason, how about Brevard Health Alliance?
So being on GE Centricity, it's limited in that we can't link it to automatically feed into our current system, but we are hoping to implement a similar fashion where Audacious Inquiry automatically feeds into eClinicalWorks once that is completed. But currently, so I log into the ENS website, and then I download each day a spreadsheet then, and then I'll filter the data by hospital, receiving facility, and then I'll remove any duplicates if applicable. Say if I combine it with another list that from patients who still had to be reached from the previous day, I'll just remove duplicates, so it's just one patient then, and then disseminate it across to the ED Navigator team. I send them a spreadsheet each day.
Pam, this is Diane. I just want to clarify one thing again for our listeners today, is that Brevard Health Alliance is in a unique situation in their relationship with the hospital that manage their Centricity system. So if we have any listeners on the call today that are using Centricity, it does have the capability to do what Dr. Hein is describing with what they're doing with Athena. So it's definitely available, and many EHR vendors can do this today. It's just a matter of whether they will and charge for it.
Okay. So it's, there is that additional cost, and that is not covered under the funding. So that would be an additional cost to the organization. I'm looking to see if we have, I don't see any other questions. I did get notification that, yes, Diane, you did answer Deanna's question, and she thanked you. So
very good. Glad to help.
I'm looking to see if there are any other questions.
Pam, could you remind us as to when this current grant funding runs out? Because I know several health centers have been thinking about it. I know it runs out sometime soon, and it's only good as long as the money is there. It's first come, first served basis. So tell me again what that timeline is.
The end of it goes with the federal fiscal year, so the end of September. So September is when it would end. However, if we run out of money, we run out of money. So the last date would be in September, and just depending on if the money is available. But so definitely contact us if you're interested now. You can, like you've heard from these gentlemen, you can try it for a year. We've heard other people say that 1 year has really been beneficial for them in being able to make the argument or to demonstrate that return on investment and the reason why, and also why it should be used in the future, as well as actually finding a way that it becomes cost effective to use the service.
Thank you, Pam.
Sure. And once again, with that, it doesn't look like we have any other questions for today. If you do have questions, you can always reach out to me. Diane, I did not put your contact information on here, but if you reach out to me, I can put you in touch with Diane. I do want to let everybody on the call know that we do have a Florida HIE User Summit that is coming up in May. It's May 20th at the Saddlebrook Resort near Tampa. So go out to our website. It's florida-hie.net and take a look at our agenda and see if that's something that you might be interested in. It always is really good. We have it is a user summit, so the users actually of HIE services share what's going on. We have some national folks, as well as Florida users of HIE that share what they're doing. Sometimes it just sparks ideas about how you can utilize information or how you can improve a workflow process utilizing the HIE in your area. So check that out. My contact information is here. You can always reach out to me. If you are FQHC that would like to have some additional assistance, Diane and her team, Susan Leonard, and the rest of the team are wonderful and have been very helpful to many of the FQHCs here in the state of Florida. And I know that Diane is willing to help you out. Please reach out to us if you have any questions, would like to learn more, want some additional help if you're already using the encounter notification service and need a little bit more help in trying to get it integrated into your workflow. I know Diane's team would love to work with you on that as well as us here at the Agency for Healthcare Administration. So please reach out to us. These slides will be made available. We have recorded this presentation, so we will send you a copy of the recording and a copy of the slides as well. So we hope you enjoyed today's presentation and that the information shared by our panelists today has been valuable to you. We thank you for being part of it. We thank you very much, Diane and Dr. Hein and Jason, for sharing with us today. We really appreciate you doing that.
Have a great day.
You too. Everyone have a wonderful day, and until we meet again.